so easy. Brzezinski's and Koenig's are freebies. There's no reason why you should get these wrong when they ask you how to assess either or of them, or prescribing it and knowing the name. We're gonna go over with it. Look at Koenig's. Koenig's sign, resistance and pain with extension of the client's leg from a flex position. It's gonna show you what that means.
Koenig's sign is a test that identifies meningeal irritation. It's often positive in clients who have meningitis or subarachnoid hemorrhage, and it's sometimes positive in those who have a spinal cord tumor.
Good morning. My name is David. I'm going to be your nurse today.
Good morning.
How are you feeling today?
Yeah, my sore. My back sure hurts.
So if they show you a picture of what somebody's doing, you should be able to identify.
Before we get
Koenig's.
started, I just need to verify your full name and birthday. Can I see your bracelet?
Jeremy Moran, 10-4-79.
Very good, Mr. Moran. And because you said your back hurt, your doctor has ordered a couple tests for you today, okay?
Mm-hmm.
Place the client in the supine position.
Now lift your bed.
Okay.
Now, Ms. Moran, the first thing I'd like you to do is place your leg on top of the blankets for me.
Flex one hip and knee and then straighten his leg from the knee. Some clients might feel discomfort with this movement, but they should not feel actual pain.
And then,
Oh, that hurts right there, right there.
now,
When a
the key thing. So you flex it, right, which means they come up, and as he extended it, not only does he feel discomfort, they say you're not gonna feel pain. They'll feel pain. Okay, like as you extend it, not only does he feel the discomfort and pain, but there's a reaction that he has, which is look at his neck, look at his head.
feel actual
They
pain.
don't come up.
Oh, that hurts right there, right there.
When a client indicates pain and resistance in the lower posterior thigh, Koenig's sign is positive.
So the pain or discomfort will be in the lower posterior side of the thigh, which is right here. As they're stretching out, you'll feel discomfort or pain, and the reaction to have is that their head will come up to try to relieve, to try to relax, okay?
I also want to check this leg too. And again, stop me if you feel any discomfort.
Okay. Okay, yep. Hurts.
See? Koenig's. Now, the way that I remember Koenig's is K, Koenig's, you look at it at the knee. Right, you're maneuvering their knee, you're flexing their knee and then extending it. Next one. Brzezinski's.
All right, Mr. Moran, for this next test, I'm going to be moving your head and neck, okay? And I want you to tell me if you experience any discomfort.
So the first one, if you look back at your books, okay, so these videos are in your ebook as well. If you look at it through the online, it should be there. So you see that we say resistance and pain with extension of the client's leg from a flex position, which is what they're doing. Positive Brzezinski's is flexion of the knees and hips, so they'll bring their knees and hips up when occurring with deliberate flexion of the client's neck. So now we maneuver the neck, and you'll see that the legs
When I do that.
will react.
Brzezinski's sign is another test that identifies meningeal irritation. With the client supine, place your hands behind his neck and flex his head towards his chest.
All right.
See? They come
Yeah,
up.
that does hurt.
This movement should not cause any pain or elicit reflexive motions. However, with meningeal irritation, the client will feel pain and stiffness in his neck, and his hips and knees will flex. This is a positive Brzezinski.
So do we understand what a positive sign is? When they have that reaction that we're looking for. Now, they don't react or they don't feel it, and it's negative. And they're not reacting to the reflex. Make sense? Okay. So I show the videos because on occasion, they show an image, and it's like, you know, the nurse is gonna test For XYZ, what should you show? And then it shows like the 4 pictures and, you know, if the nurse doing a certain thing, you should know how you're testing that. Good? Okay. Yes.
If you're positive for one, are you gonna be, is it like definite positive for the other, or is it gonna be either or?
You either or, but generally both. And in some cases, again, with probably not a severe inflammation, you may not even be positive. Doesn't mean you don't have meningitis, but it is a way to check for, how much meningeal, like irritation you have. The more inflammation and irritated, the worse you're gonna feel it. But just because you're negative on this, you're not gonna be like, oh yeah, no, I don't have meningitis.
Yeah, the spinal tap, right then?
The spinal tap is gonna confirm. Alright, so lab test. Bottom of page 41. Urine, throat, nose, and blood cultures and sensitivities. Okay? Not definitive for meningitis. This is the key thing, that while they're running all these tests for blood and urine, and they're trying to identify an infection. So while it's not definitive for your meningitis, it already begins to identify what organism you have. And you can begin antibiotic treatment. This is a lot easier and faster to do. Blood draws, urine samples, CBCs, easy compared to then getting a spinal tap. You can at least start antibiotics already, okay? So the next thing is, the CBC, obviously your white blood count will be elevated. Why is your white blood count elevated? Infection. Now, diagnostics, on the next page, 42. CSF analysis is the most definitive diagnostic procedure. Cerebrospinal fluid is collected during a lumbar puncture performed by the provider, and we went over how to perform those. Results that indicate meningitis, and we're gonna go over it. So, for diagnostics, you're gonna do a lumbar puncture to view the cerebrospinal fluid. Now, here are certain things that you should know about it. Okay? The appearance for bacterial is cloudy. And that's a key one I need you to know. But for viral, the CSF is still clear, as it usually is. So just as they draw cerebrospinal fluid, you'll notice that it's cloudy. There are obviously white blood cells elevated in both, and protein, but bacterial has a decreased glucose. And a good way to remember this is that the bacteria is feeding on that sugar. It's feeding on the glucose. So that's why it's decreased. You don't have as much because the bacteria is using it as feed. And then elevated cerebrospinal fluid pressure. This is present in both. Okay? Nursing care. We good on this? Nursing care. I cannot stress this enough. Isolate the client as soon as it is even suspected. Patient comes in describing these findings, a fever, you isolate them to prevent the spread. Maintain isolation precautions per hospital policy. Initiate droplet precautions in a private room until, so they're no longer contagious, 24 hours. Let me write this. Until 24 hours after antibiotics have begun. If other antibiotics, no longer contagious from their oral and nasal secretions. Standard precautions, clients with bacterial meningitis might need to remain though on droplet precautions continuously. Standard precautions are implemented for everybody with meningitis. Implement fever reduction measures. Cooling blankets. Be worried about the fever. Another big one. Decrease stimuli. They have a severe headache. The noise and light, everything bothers them. Decrease stimuli to keep them comfortable. This also involves, the next bullet point is, quiet environment. Provide a quiet environment. Minimize exposure to light. Whether artificial or natural. Another key point, head of bed, 30 degrees. And monitor for ICP. And we'll go over it soon, how ICP looks like, maybe next week. Monitoring intracranial pressure. And there was one that we skipped over, which was, you must report this to the health department. Keep track of it. Make sure you don't have a little outbreak with all these peeps out here not getting their measles vaccine. Messing up Disneyland for everybody. That's why I kick kids, man. Little reservoirs of bacteria and virus. All they look, I just see it as just infectious creatures. They don't wash their hands. They be coughing like this. Stay away.
When Miko was coughing, she was playing, she was sitting on my lap. She was right in front of my face. I'm like,
Hey, last few points, I missed the right side. So, tell them to avoid coughing and sneezing, which increases ICP. Another one, maintain client safety with seizure precautions. Replace fluids and electrolytes, that's obvious. Older adults are more complicated, and watch their vitals for shock. Now, medications. You will treat this with ceftriaxone, so usually a cephalosporin. Ceftriaxone or cefotoxin, it says, with vancomycin. 2 antibiotics. Now, phenytoin is what? To prevent seizures or seizures. This is if they happen. You give acetaminophen and ibuprofen for
headache.
fever and pain. And this is the medication. You can use one of these 3, Cipro, ceftriaxone, or rifampin, to give to those who have been in close contact with the client and are possibly have been contaminated. Now, complications is one. You can develop increased intracranial pressure because of all the inflammation. And this can lead to, again, as we stated, brain herniation. So how do you know that they're developing ICP? What will you report? Decreased LOC, so they're less conscious. pupillary changes. And impaired eye movement. Eye movement. Okay. Pupillary changes, usually they can get like oval shaped or small. And a late sign, like damn, they're probably dead or about to be, is when they finally dilate and don't react to light. So they can get oval shaped, not as reactive, but once they start reacting to light and they dilate a lot, they're in deep water. And what's the treatment for ICP as we have all this inflammation and fluid buildup and all this? Which diuretic? Mannitol. You'll give mannitol to treat this, treat the ICP. Especially whenever you have cerebral, specifically fluid buildup in the brain, cerebral edema, or ICP, you should know mannitol. Come on, people, term 3.
Damn, bro.
I lose hope every hour. By the hour.
What is the last word say?
This? It says dilate and don't react to light. Light. Okay, so mannitol. Y'all could have laughed, but Krishna was the only one who knew that it was mannitol. So, what's specific about mannitol?
Check glucose.
Yes, but like most diuretics, we have 4, right, that we learned here. Loop diuretic, also called the high ceiling loop diuretic.
Hindi ka siya yung light eh.
You have 4 diuretics that you should have learned in your form class. Loop, thiazide, potassium, and osmotic. Now the other 3, the first 3 are commonly known by you and are pretty straightforward in the fact of how they work, which is depending on where they act on the kidney, they'll just still make you pee a lot and therefore get rid of your fluid. Acts on the distal tubule, on the proximal tubule, I forget what this one is. And then osmotic, okay, will work, or sorry, loop of Henle is where it works, distal and proximal. Now, it's not specific that you know where they work, but what that causes. With it working in the loop of Henle, you just pee a lot with all the normalcy that it happens, which means you get rid of sodium, potassium, everything. This one, right, requires kidney function, while this one does not. Potassium will save your potassium with your kidney function. But osmotics do what? They do pull water and obviously get rid of ICP, but how? You're almost on the right track. All of these will make your kidneys overwork and then urinate. Osmotics will change your blood osmolality. It will make your osmolality higher. Now, if you don't remember what osmolality is, this is how concentrated your blood will be. That goes for any fluid. The more osmolality there is, the higher the fluid, the higher the force of pull. Because it's more concentrated, water will want to be drawn to it. We all hear people say water follows salt. Because salt in fluid develops what? Osmolality, pull. So it makes your blood osmolality higher. Now, as you have circulation on your brain, because you have some, right? all that fluid will then chase to the vascular system, and it'll draw it away. You can think of it like this. You have your brain, and it's full of fluid, okay? And it's full of fluid. Now, as your blood vessels come in and out, right, and they're passing through and whatnot, right? All those vessels that lead to blood, since they become so concentrated with mannitol, it increases their pulling power. The water in your brain will cross that barrier through osmosis, which is a concept we learned. And that water will then go into your vascular system, back into your body. It gets drawn away from the brain through your vascular system because you're changing your blood osmolality. So it pulls the water from your brain to your vascular system. Yes? So what's the complication? If my blood is too tonic, I'm pulling fluid from everywhere. With more fluid in my body, I will develop fluid overload, heart failure. Okay? Now, this may seem like complex, but I always share this every term 4, because that was a question on my NCLEX. How does the osmotic diuretic mannitol work? Now, what does it do? Whenever you're using it, and it was like a long, like 2-sentence statement for every answer. All I wanted to know was, how does it work? So I make a fact, I've always been doing the form in term 3 to make sure you guys understand. At a very big, you don't have to know like a scientific, like, oh, blood is molecular, at least what's happening. It's pulling fluid from the brain and the eyes into your vascular system by changing osmolality, the pull. Yes? We don't have time to get into fluids and whatnot, but hence fluid imbalance and renal, so key in term 3. Term 3 is the beef and potatoes of your med surg. Cardio, endocrine, renal, fluids, and ABG. If you understand those, you understand majority of the body disorders that we have moving forward. Yes? Okay. So, increase ICP, give mannitol, watch out for pulmonary edema and heart failure from the fluid overload. Yes? Jennifer? That's what I'm asking. That's the problem, I need it. All of you, yeah, all of you need to go, because we're confused as to which, go see Carla together. Yeah. So, take a break, be back at 10, and the three Jennifers go